Okie doke. Hi, everybody. Welcome. I'm Karen Borkovink. I'm the Executive Director of LA Tech4Good. Thank you very much for coming. And on behalf of our organization, we're really excited to host two leading physicians in LA, Dr. Ilan Shapiro and Dr. Juan Espinoza. Just in case you want a little intro to LA Tech4Good, we are a platform that showcases and amplifies tech-informed social innovation. We have a history across nonprofit, social enterprise and the tech industry, and we're excited to be entering into the tech healthcare space, meeting some new friends today, hopefully. Thank you to our community partner, Jessica Santana of Elevate LA, for making connections and helping with our marketing. And you can find us, connect with us on social, and donate at latech4good.org. Today's conversation on telehealth is part of our Digital for All initiative, which is our response to the COVID-19 epidemic and the urgency of digital inclusion during the quarantine. It's also taking place in the spotlight, with a spotlight on healthcare inequalities for people of color that have been as well in the spotlight with George Floyd's murder. Our goals for this event are to share successes and challenges in telehealth implementation, to share recommendations that support equitable telehealth engagement, and to ultimately contribute towards health and wellness for everyone. Short intro, I'm going to turn the conversation over to Drs. Espinoza and Shapiro. They will introduce themselves and dig right in. They have a lot to share, so I want to let them have the time.
Wonderful. Thank you so much, Karen, for the introduction. Hi, everyone. My name is Juan Espinoza. I'm a pediatrician at Children's Hospital Los Angeles, as well as the medical director of the Innovation Studio there. And it's my pleasure to host a conversation with my friend Ilan Shapiro, who's also part of the healthcare community. We actually both work together, so even though I'm at CHLA, we both see patients within the AltaMed network of federally qualified health centers, or FQHCs. And he's also a physician who's very much interested in the role of technology and digital health and improving health outcomes for underserved populations. I want to really quick just say thank you to Karen and her whole team, everybody who's helped put on this event. All of the organizations came together to make this happen. I think the events of the last 3 to 4 weeks, which are just, in some ways, just a microcosm of what's been happening for hundreds of years in the United States, really have put a spotlight on the unequal treatment and unequal access that communities of color, particularly Black communities, have faced in the United States. There's a paper today was published from Harvard talking about the inequalities in the mortality rate in COVID-19, particularly faced by Black and Latino communities. And so, I think I wanted to bring that up just to say, for 2 reasons. One is that I think in a time where silence feels complicit, it's important for all of us to voice our support for Black Lives Matter, and for the variety of other social movements that are helping to spur real change in our healthcare system, but also to figure out how do we play a role in making those positive social changes. Ilan, anything that you want to say before we get started?
It's a pleasure to be here. It's very exciting to actually be with people that are making a difference and actually pushing forward the way that we think and pushing the boundaries. And one of the interesting things is that Karen and Dr. Espinoza, and even with Carlos, we have met each other in different virtual worlds. And right now, the past weeks that we have been trying to do this, we have a common goal. The common goal is actually to share what we have, what we know, and most importantly, to hear what's happening out there. By no means we are the experts here. Actually, all of us are experts in COVID times. We have never lived to this. We have never done this. Then we're here to share.
Perfect. Awesome. Thank you, Ilan. So let's dive right into it, because I know that there's a lot to discuss. And then for all of our participants, please feel free to put in your questions into the chat. And Carlos is going to help us moderate the conversation and bring in some of the participant questions. We'll also leave some dedicated time for Q&A at the end. But yeah, like I said, please, if you have questions as the conversation is evolving, put them in there, and Carlos will make sure to bring them to our attention. So Ilan, let's dive right in. So tell me about what has been your experience doing telehealth and during the time of COVID-19.
Well, I come from a world that, in the fair qualified health centers, because there were limited funds for us, it was not something that we did. It was something that we planned to do in the future because we knew that that was something that will benefit our communities. But we had the infrastructure for it. We had actually the big box for it, but we never thought that we actually will be using it before 2 years from now. I'm actually enjoying it a lot. I feel a lot that I still have the memories of my pediatrician coming to my house with his bag, with his stethoscope and blood pressure cuff, and giving me my vaccines and medications in my house. Then whenever I start doing telemedicine right now, I feel a different level of that, of the old classic pediatric doctor going to your house, plus the technology all at the same time, being safe. And sharing what's happening on the household, seeing the interaction with the kids, seeing a different way, because I have never met Dr. Espinoza, nobody that actually likes going to a doctor, nobody. Then actually seeing the patients and the parents and the family members interact in a different way inside of their house and hearing the stuff. Of course, we have limitations of a lot of things, but I'm enjoying it a lot.
Yeah, I think you picked up on a thread that has been my experience as well, which is there's a level of a new level of intimacy, for lack of a better term, of really getting to know your family. Because the only thing on the screen isn't just their faces. You get to see their living room or a bedroom or their home environment, and you get to learn a lot about them. And I feel. Do you find that your patients are more comfortable over telehealth, or do you think in terms of just how they open up to you, or how is that? Is that different? Is it better? Is it?
I have not felt I haven't felt a barrier on communication part of sharing, and sometimes actually the part that we are in complete contact, and there's no computer, there's no kids running around, there's not a lot of things. Sometimes actually I feel that even the communication is better because we have like a straightforward conversation between me and them. We're seeing each other, the computer's on the side, all the barriers that we have in a regular clinic, in a regular clinical setting, I don't have them. Then it's just, I just have fun.
Yeah. No, I agree with you. I think, today, literally this morning, I was doing my clinic via telehealth, and I had a visit with a 16-year-old male. And honestly, it's the most he's ever spoken to me in the 8 years I've been his pediatrician. Because it was just me and him, and he was at home in his room, and he just felt like talking. And yeah, I've been his doctor for a long time, and today he said more words to me than I think the last 3 years combined.
And I mean, I'm enjoying the moment. And right now that you're talking about that actually brings me a lot of things. Right now, I'm behavioral health as a pediatrician. It's something that you need to ask the parents to leave the room. There's a lot of things going on the same room. But right now, it's kind of a natural thing. It's like, can you give the telephone number, and they'll get back to you as a parent. And I think that you're right. It opens a lot of good conversations.
Yeah. So obviously you and I, and really the AltaMed in general, we take care of a predominantly Latino population, many of whom have limited English proficiency, maybe are either Spanish speaking only or primarily Spanish speaking. What have been some barriers to the telehealth implementation that you've experienced?
On the patient side, it's the thing that I'm appreciating right now, and we're trying to figure out how to measure this, is that a lot of the literature showed us that there was a barrier on the internet gap, the way that we're doing things, the way that we're doing a lot of thoughts, the way that we thought that they had an internet gap, that they had like poor telephone communication and that stuff. But in my experience, and the thing that we're seeing here in the clinics is that they have the community has cell phones and they have like decent internet. It's not, I would not film or produce a movie through that internet connection, but it's decent enough that you can see a rash. It's decent enough to have a conversation and have that back and forth. But the problem that I'm seeing is that my patients and families are not used to using the cell phone as a healthcare tool. They are used to using texting, Netflix, absolutely everything. But when you use it as a tool for health, that's where we're kind of broken, because they are not used to hearing the doctor. They are not used to like going to the application that they see the medication, and instead of waiting 400 billion or whatever time they wait on the phone or trying to get something, they can actually do a click and it happens. And it's the challenge that we're having right now is to amplify the message, to amplify, this is the things that you have as a tool. You can choose to do it or not, but it will facilitate our conversations and for sure our relationship as a patient and physician relationship.
Yeah. And how have you, what about when a family's having, oh, sorry, was there a question?
No, it's my...
Oh. That's what happens when you're in a clinic. So, I mean, it sounds like what you're saying, what I hear you saying is that, your patients have access to all the same tools, cell phones that can connect to the internet, that can connect to Wi-Fi to host these calls. What about when there are issues with the technology itself? So, say a patient whose English is not their first language and they're having trouble with, let's say, whether it's WebEx or Doxy.me or Doximity with the technology, how do you help them troubleshoot the technology? Are some of those, are you creating Spanish language guides to help families, or are the companies stepping up to the challenge and making sure that they're offering tech support in Spanish and in other languages?
We are doing absolutely everything that we think that will work. We have healthcare educators when we're doing their group visits, making sure that they understand how to connect, doing one-on-ones, explaining as part of the group visits how to do things and how to amplify the same voice and do repetitive things for them and for everybody else. We have done a lot of most of everything we have in Spanish, English. We're now moving to other languages. That way we have a group for Vietnamese patients. We have another one that is Mandarin. Then we're trying to gather the big groups that we have. It's a slow process, but it's important. At least Spanish and English is dominated. And the idea that we have, for example, with at least with the phone calls, we actually have, so you can, if you're not proficient on that language, we actually have a operator that will do and help with the translation, and it's working marvelously, and everybody's loving it, and the patients feel very, very comfortable. Of course, we all want to have our doctor from our childhood being there for us all the time in the same language and everything, but it works, and the quality, most importantly, and the patient appreciation of the interaction, it's high.
Yeah, no, and just on that point about the quality of the interaction, I see a question in the chat around, do you feel that you have more time to spend with patients on telehealth versus in person?
Oh yes, and it's kind of reverting a lot of things, because when you are doing the regular checkup, you need to do the computer, you need to do the patient, you need to do the physical exam, and right now it's actually like 15 to 20 minutes of one-on-one talking time, and you need to be very clear. They need to be very clear with you, and you need to go back and forth with the conversation and information that you're having. And I'm enjoying that a lot, because you end up actually asking other stuff that you usually don't ask. A well-rounded physical exam, at least on the initial part, that you have all this stuff about how's your house, do you feel safe, and other stuff that sometimes you just rush to it, and you're just waiting to hear if there's cues of problems. But right now you have time to ask for it, and not only that, to give a lot of advice at the end of the conversation for them for the family, and especially right now that it's COVID times, you know, that behavioral stuff, that, you know, giving them tools for food pantries, making sure that they have behavioral health, you know, outlets, and that's actually helping a lot.
Yeah, and I think that resonates a lot with my experience doing telehealth as well, where I find myself, my visits are some of them are actually shorter because, you know, because the connection feels more immediate and more intimate, right? Like they didn't have to go through, you know, taking 2 buses, spending an hour and a half, you know, figuring out how to get to this clinic. You know, they just turned on their phone. That's all they did, right? Like their investment was lower. So a lot of my patients have felt, you know, like, oh, I just need to talk to you about this one thing. I think when the barriers to accessing in-person visit are so high, I think sometimes patients have this like, listen, if I went through all this work, we're going to spend a half an hour and I'm going to tell you everything. And I think by lowering the barrier to accessing care, at least for some of my patients, you know, they almost self-sort. And they're like, oh, what's actually important? Because they know that if they just want to talk to me again, it's literally as easy as sending me an email saying, hey, I have another question. And then I ask my office staff to send them a link and we set up a telehealth visit and we do it again. And so maybe we talk again in a week or in 2 weeks. And so, yes, some of my visits have actually gotten shorter, but they're higher quality because we talk about what actually matters to the family. And yeah, I think I also noticed that the whole process piece, right? Many people aren't aware of all of the things that have to happen to see a patient, right? There's registration, there's the insurance check, the MA, the vitaling, the rooming, the checking, the EHR. So even though the patient's appointment is at 10:20 a.m., by the time they're ready to see you, it's like 10:45. And so now you're running late, but you're still seeing the other patient. And so none of that stuff is there. And so you actually get your time with the family.
I completely agree with you. And one of the things that I probably you share the same thing with me. I'm impressed on, you know, whenever a patient comes to our clinics, no matter if they are 0 years of age or 120, they do, it's an honor to have them here because we know all the social determinants of health that need to align for them to actually come and do something in our clinics. That's why we try to, you know, wrap around a lot of services with behavioral health, making sure that if they need a dental visit, to make sure that everything is aligned on the same visit, because it's a miracle when they are here, because, you know, a day of work, you know, there was no money for the car. There was no gas on the car. There was no bus, or the bus actually, you know, whatever. And when they come to us, it's a miracle. Right now, I think that the health divide will start expanding. I think that, you know, and it will melt away, because if we actually have right now numbers, and I feel that we are moving forward with this, and we have a little bit of things like a weight scale, and we send them as part of the things that they need. They don't need to do hula hoop dancing. They don't need to lose a day of work. They don't need to pray for a miracle to have the car work, or actually get a car for. I think that all of these things will decrease the cost per se of the visit, improve quality, and for sure the relationship with me and the patient, because they're going to show up. They're probably going to be at work and go like, you know what, I need my 20-minute break because I need to talk with my doctor. And bam, boom, done. And you're right. They're not going to use that 3 hours of time to come to your office.
Yeah. There's a really great question in the chat about, you know, how have you had to adapt your behaviors, the way that you do medicine, the way that you deliver care, to make it work better for telehealth? And if you have any tips on things that have worked really well for you and for your patients.
I'm for telehealth, I'm loving the certain tools that we have. One of the tools that is free and I love is Doximity, and the same thing as Doxy.me. And actually the visual part of it and the component of it, and trying to get all the rashes, get all the tricks, making sure that they have some type of light to see the throat, and things that, you know, like things that you become very innovative on the way that you approach certain things. You know, you can actually thoroughly check them out. You can check for rashes. You can do a lot of things. And and of course, the part of hearing again the what the patient really wants. I always do this joke with residents and students and coworkers. When I'm a patient, I always have my hidden agenda when I go back to my doctor, right? You have that thing that you actually want to share and ask, but you kind of have other things, and after that, at the end, you go like, oh, by the way, the rash that I really worried of is this one. And right now, you actually have the conversation and the time to go directly to the problems, to understand what they need, and and actually solve the problem that they want to have solved. And I'm enjoying it.
That's awesome. That's really good to hear. I think some other things that I think help that I've experienced is, especially for the first time a patient is doing telehealth, is to just set expectations and normalize. Right? Say, so for example, I have a 2-screen setup here, and so I have my EHR and my prescriptions open on this screen, and I have my patient on this screen. And so, even though I'm looking at this camera, I would let them know, hey, just so you know, I have your chart open right here. And so if I'm going to prescribe you something, I'm going to turn away a little bit. But if I'm breaking eye contact, that's why I'm doing it. And just having a little bit of what's sometimes been referred to as webside manner, right? Instead of bedside manner, just like making sure that you know where your camera is, that you're looking at your camera, and then you say hello, and then you set up a time a mechanism to reconnect. The other thing that I found, and I don't know if you've experienced this, is, for a lot of our families, it's one parent is the one that brings their child all the time, and that has to do with who has work and work schedules and all these other things. But what I found is that with some of these telehealth visits, all of a sudden I'm meeting all sorts of family members that never came to the clinic before. I don't know, have you had that experience?
Oh, I know most of the abuelitas that come with me. The abuelitas, they know me, I know them, I know about everything, the diabetes, everything I know about them. Right now, to see el abuelito, the grandfather, and you're right, I'm telling you, I really feel that we there's a lot of technology gaps that we have, and there's a lot of things that we with technology, we push away the patient. With this one, I really feel that, we're getting closer in a different level. With even though that we have that barriers and social distancing, we don't have a soul distancing. We don't have that behavioral health, distancing. That I agree with you. That's something that I hope that doesn't go away, especially right now, that it's something that we're now starting to have. And most importantly, everybody's actually loving, and the patients are, I can do this, and I have a rush. I don't need to wait like whatever time to get a visit with you. I can actually just call you and we can do something about it. Yeah, we can schedule it. And that things are, I think that will bring a higher expectation. It will create equity on the technology part, and an equilibrium on the things and expectations that we can offer to our communities. And I hope that doesn't go away. Yeah.
Speaking of it going away, I'd love to get your perspective on this. The ability to do telehealth is not so much a technical one as it is a regulatory one. And different parts of the U.S. healthcare system have adopted telehealth at different times based on basically what they're allowed to do and what people will pay for. And by people, I mean payers, insurance companies, Medicaid, Medicare. For AltaMed is an FQHC, a federally qualified health center. And under CMS regulations, FQHCs were not allowed to do telehealth for primary care. So they could do telehealth to bring in a specialist. If you were in a rural area and you needed to get a cardiologist, you're allowed to be a distance site for telehealth and to connect to like the university medical center at the big city. But primary care telehealth was not allowed. And so most FQHCs, like AltaMed, it wasn't part of their roadmap. Like, why would we bother? Like, we're not allowed to. So how did you go from we're not allowed to we're seeing hundreds of telehealth visits a day in basically in a few weeks? Because that is a massive undertaking.
We had, I can tell you for sure, we have an amazing team. Our doctor that is in charge of that, our chief technology officer is Dr. Lee, with Raymond and Loey, and our CIT. Then they both aligned the docs. We knew that we needed to create an implementation plan that it was for 2 years to schedule it in 2 weeks. Then we went from 0 televisits, 0 telehealth, and some digital group visits somewhere to having almost 50-50 or 60-40 or 40-60 depending on the week. Then it was an amazing thing from aligning, and most importantly, and I think that this is one of the key messages that I have for my heart and for everybody else. We were suffering a lot of the times with something called meetingitis. You create a meeting of the meeting for the meeting to choose the color of the paper for the meeting. Then right now, when we were aligned, we had a mission and we needed to implement and do things. We shoot for the sky, and we did it. And we did it. Yes, of course, there's like certain gaps that we still are closing to figure out what's the best technology, how can we directly implement it from our EHR. But it was a lot of docs that were there and improved the concept that technology, it doesn't need to be like high tech, doesn't need to be a nuclear weapon reactor that nobody knows how to code for it. The technology that we have already at hand that we can implement for the community, it's already cheap, it's efficient. And right now, as we're talking right now, it's working and it's making a difference on the community. And I think that the way not only the FQACs, but actually the community perceives these things, because they saw it on TV, they saw it in certain things, they saw it even in commercials, but they said, well, I'm in a community health clinic, I will never get this. But in reality, it was like a mental gap. It was a mental barrier. There was really no barrier. It was like just flipping the switch. If we can do it in 2 weeks and we're making a difference, and that's the way that we're implementing health for our communities, it's something that needs to stay here. It's something that it doesn't need to be just a CMS or a Medi-Cal or Medicare or anything. This is the new way that we need to do things.
I couldn't agree with you more. I think the 1135 waiver that the Health and Human Services Department issued, Medi-Cal's ruling that came out on March 19th to really just expand telehealth and remove as many barriers as possible, made the difference. And so it's nice when government agencies and regulatory agencies respond appropriately. These days, it feels like a rare event, but it was really nice to see our partners in Sacramento and in DC really realize that they needed to remove those barriers, and they did it really fast. So my hope is that they will realize that there's no reason to go back to the way it used to be.
I think that, sometimes we as doctors, we try to champion things, or sometimes like healthcare providers or hospitals or systems, you can call it, like one-sided. Right now, I think that the country is ready for a change, and we have the technology. We have, yes, there are certain communities that don't have internet and certain things, and we need to figure out how to better serve them. But these are a different level of tools that we want to use, and I think that the next generation is the things that you and me are doing is how can we use gadgets and weight scales and monitors and other things to make a difference. And first of all, answer the question, is it worth it? And the second question is, how can we better and effectively do this? Because in the past, having a weight scale that was talking with a cell phone or sending you information was very, very expensive. Right now, it's doable. And if you put all that together, for example, if you prevent a CHF patient to go to the ER, the weight scale is already, it was for free. Then you have a lot of things that we can do with asthma, with smart inhalers. We can do a lot of, like a starter kits with a stethoscope, with an otoscope, with a lot of things that parents can safely do at home. And it will be like a starter kit for them. And it will be part of any community clinic. And it helps, because if they just don't go to the ER once, it pays for itself. Then in the lifetime of our patients, no matter what age they have, if they have this starting kit, and we can avoid a couple of ER visits, a couple of hospitalizations or complications from diabetes, from asthma, from whatever we have in front of us, it's the new way of helping the world.
Yeah, no, certainly I agree with you. I think that I'll give the devil's advocate here that says, well, who did you save money? And like, where is the incentive, right? So at AltaMed, and you experience this as do I, because we are our own IPA, we have a financial incentive, Independent Physicians Association. So for those of you who are not in this part of healthcare, Medi-Cal gives money to HMOs, HMOs contract with IPAs, IPAs hire physicians, and at each one of those steps, there's a bunch of like wasted administrative costs, but then there's also a contracting, and different costs are allocated to different people. So an ER visit might, depending on your contract, is the responsibility of the IPA, whereas, for example, a hospitalization is the responsibility of the HMO. And so one of the things that you're talking about is that aligning of financial incentives, right? Like if the patient shows up in the ER, that costs you money. And so you are very much motivated to bear the cost of the scale or the starter kit or the telehealth platform, because not only are you delivering better patient care, but you're actually, it's a financially good decision, right? Because it's gonna, that ER bill is gonna show up at your door for $800, $900, $1,200, as opposed to the $25 Withings digital scale.
Completely. No, and everybody wins, and it's all about piling up, and it's investing on the things that actually make a difference. It's investing in, like, we have a lot of, for example, how many MRI machines can you add on to a hospital, right? But in the other way, if you have a smart inhaler and you're preventing and understanding what's the concept and what's happening with your patient, on the long term, that will help close the wellness gap for that patient more than that MRI machine that is just idle waiting for something. Then I think that's the conversation that we need to have. That's the research that we need to do. That's the academic talk that we need to have of now what? What's our, everybody's talking about, I hate this term, it's so catchy, but what's our new world? What's our new reality? What's our new normal? And I think that, me as a physician and as a patient and as a father, I will feel horrible if I need to revert all the good things that I have right now to talk to my doctor by telehealth, or just using the app to get my prescriptions or other stuff. And I see this as a father, as a pediatrician, as a medical director, and of course, as someone that loves public health.
Yeah, no, I agree, and I hope that all of our regulatory agencies and our partners in Sacramento are really carefully paying attention to the improvements that this has led to in patient care, and will hopefully create mechanisms for us to continue to deliver care in these ways. There's a couple of questions around this, and I wanted to get your take on this and see what you're doing. You mentioned, so let's say you encounter a family who wants to do telehealth, but they can't, right? They don't own a smartphone, or they don't have a computer, or they don't have access to Wi-Fi. Obviously, AltaMed has a huge commitment to social work and social determinants of health and helping families with wraparound services. Have you figured out any strategies to have to help that family who wants to do telehealth but is economically barred from doing it?
There's a lot of programs, and I can actually share with Karen afterwards the links that they will give it for free. There's a program that one of the vendors, True Connect, if you have certain services, social services, you can actually get access to a line that will have internet, and they will have, like, apart from cell phone, texting, and actually internet included. And those are working amazingly well. And we're trying to figure out how to work with them and create, like, partnerships. That way, if they don't have one or they need to change, the program is there. It's federal dollars that anybody can have access to it if you qualify for it. And we're trying to channel that conversations to certain areas. We'd love to tell you that my dream is that any fair qualified health center or community center will have, like, starting kits that will just send the blood pressure monitor with a thermometer, with the otoscope, with the ophthalmoscope, and the stethoscope, and that way and of course weight scale, and they will send us that information to us. But in the meantime, this is the best thing that we have.
Yeah, no, that's fair. And Karen just put a link to everyoneon.org, which is a portal for finding low-cost internet access. We've used that. We've also used the California Lifeline program, which has been around for a long time. Patients who qualify can get a free phone and a free plan with both minutes, calls, and internet access. There's another group called Get Connected Los Angeles. So there are a number of nonprofits as well as government agencies at the local level who are making sure that we can use those public services to help narrow that digital divide that we think about. So I definitely, everyone who's joining us for this conversation, I recommend to check out those resources, and we'll make sure to share them afterwards. But those are, if you have patients who are struggling with access, struggling with technology, those are all great resources. We have you talked about stethoscopes, blood pressure cuffs, thermometers. Somebody in the chat asked about, what do you do about vitals with every visit? And I have some thoughts on it, but I'd love to hear your experience. Like, do you need vitals for every single visit?
You know what's the interesting part? I think that, and it's probably a combination between what I think, what I see, and how the kids and patients are portraying themselves on the other side. If you clearly see some patient painting like this, or the kid like pale and not moving, then at least you get a sense, in the same way that we do it on the hospitals, the same way that we do it with the MT teams with triaging. There's a lot of information that you get a glance in the first 2 or 3 seconds on where you are. Then I think that you can establish a safe barrier or a safe level, or where you are, just with having a visual interaction, or worst case scenario by phone. But I think that at least you need the visual part of it to help them, perceive a lot of things. But I agree. I would love to have like a smart watch that gives me the blood pressure, the temperature, and of course, the heart rate, with everything else, with oxygenation level at that moment. But I don't have any cheap, good solutions for that one.
Yeah, it's tough, because that's one of those things that requires that investment up front. And so then the question is, well, who makes it? To be able to collect it, I guess, and to give it some of the other pieces of that is that from a regulatory and documentation perspective, vitals are not required for telehealth. So if you're documenting a telehealth visit, it is not mandated that you have vitals. So you're in the clear from a medical legal perspective. And I agree. I think it helps you sharpen your clinical skills and your listening, right? Because in some ways, when you're having a normal patient follow-up visit, you just you glance at the vitals, they all look normal, and then like that part of my brain turns off. Like, oh, I don't care. Now I'm a little bit vigilant, right? Like every single time I log in, I'm like, all right, well, I don't have vitals to tell me it's fine, so I just have to look and I have to ask and I have to. So I think there's definitely a little bit of a more engagement of your clinical acumen. But yeah, for medical, legal, and billing purposes, vitals are not required. And the reality is, especially in pediatrics, right, we do so much developmental screening, so much behavioral health. Like for those visits, like vitals aren't helping. Like it's, in some ways, it's like it's a wasted 10 minutes of trying to get this 3-year-old to sit still for a blood pressure, because it doesn't help. We're here to talk about your ADHD. So, from a procedural standpoint, eliminating the vitals sometimes I think is actually a good thing. Somebody earlier asked, and I think this is a really important question, is what has been your experience with no-show rates with telehealth? Same, better, worse?
Way better. And by way better, meaning I am not seeing as many no-shows as I used to have. We have the initial trend. Then I hope that in the following months we can actually get the AltaMed, CHLA, and the AltaMed community clinics numbers. But I do feel that I don't see as many open spots when no shows, open spots when I'm doing telehealth, and it's quite interesting that probably we were right on one thing about the barriers and the divide that we had. And it was that patients were having social determinants of health as barriers. And right now we're breaking that. And it was not the cell phone, it was not the change, because we had a lot of things. We thought that they didn't have internet, that they were changing the cell phone numbers every time. And on reality, they don't change it that much, that often. And sometimes maybe, yeah, there will be a bad month and there was not money on the cell phone, but you know, the next month is on. But the major thing here is that we're better and connected, and I'm loving that. I'm very, very joyful for that point.
Yeah, no, and I'm excited to start seeing more organizations publish their encounter rates. But at least my personal experience with my clinic has been, I've never seen more patients in my life. I would inevitably have, a 20%, maybe 30% no-show rate. That was just normal. In the last 4 weeks, I can't tell you the last patient that didn't answer the phone. So certainly, so you can think of it from a purely financial perspective. Telehealth has been great. I'm billing so many more encounters. But the reality is that I'm being a little bit facetious. I'm also just delivering more care to people who need it.
Sure.
And I think that's what really matters. So hopefully to the person who asked that question, that addresses it. I know we only have about 15 minutes left. And I do want to get to some of the questions because I think people have some good sort of very specific telehealth questions. But before we get to the general, I want to give you an opportunity to tell us, moving forward, like what needs to change in our healthcare framework in order to take this up another level, right? COVID-19 has been terrible for so many reasons, but if there was one thing that it did is that it forced us to reconsider how we deliver healthcare. And I think we're doing a better job of it today than we were in February. So what else? If we're going to keep moving forward, what do we need to do from as individual providers, as healthcare delivery organizations? How do we support patients to engage not just in telehealth, but in digital health in general? What else do we need to do? What does everybody else here who's on this call need to do? What do we need to advocate for?
The first thing is there's no way that we can go back. This is the new level that we are here. We're already walking up the mountain. We are here. There's no way that we can roll back anything. Why? Because it will be bad. I really feel with all the information that we're gathering right now that this is the way that we should go. We all knew it, and this is the way that we're doing it. Now we have proof because we didn't need to do grants. We didn't need to do like academic papers. It's just happening naturally, and we have numbers now. That's one, and it's not like the cohort of 10 people that we thought that we had a grant of $5 and no, this is actually the way that we're conducting business, and it's working. We need to stop binary thinking. It's not all telehealth or all face-to-face. We can create hybrid missions right now where one of the examples that you have there in CHLA, and this is actually one of many, is that you can do a lot of things using telehealth and come and get your procedure done, meaning get your vaccines off for your kids and go and drive out. Then there's a lot of things that we can start thinking out of the box. Right now that we have technology, we have telehealth, and we have a lot of new technology. And by new, it's accessible technology. It's not that this is high tech, that it's artificial intelligence that will supplement docs. No. This is technology that we already have, that we have never used it because we were afraid we didn't have grants or there was never a business case for it. Right now, there's no excuse. We need to move forward with this. We need to create that ample vision of, okay, you need to come and do your diabetic check. Okay, well, let's start by phone. Let's see what we have. Let's talk about starters kits for the community. Because a lot of the times we see, and especially with communities of color, that they end up on hospitals because of poor outcomes of chronic care diseases, diabetes, obesity, asthma, hypertension, CHF. then you have a lot of things that you can start like changing right now if we create these hybrid moments. And the same thing with diabetes group visits, the same thing with group visits for kids, weight management classes for kids, are these creating rooms where you have the, the psychologist and this one and that, and you get the best ones of smart people, and you just rotate the patient in virtual rooms, and that will be amazing. We try to do it with clinic, with specialized clinics, with certain things that we have the RD, the social worker. We can do it more efficiently, and saving a lot of the times to patients that are very critical. They're having a lot of issues, and they want to be taken care of. And sometimes, just on time, on being on the place, on the right time, with the correct doctor, it takes a long time. Then I think that we're moving forward. We need to figure out, what are we going to do for labs? A lot of the procedures, things that we usually do, how can we better improve that? Do we send a nurse? Is it cost effective to send the nurse and do blood work for them at their house? Is it worth them going to a centralized place? Is it safe? Then there's a lot of interesting things there that I'm looking forward to be part of.
Yeah, absolutely. Well, thank you for that. I think you gave us a lot to think about in terms of how we can all be helping to keep this momentum going. I want to take some time to go through some of the questions, and I'm going to try to pick some. I know we only have a few minutes left, so I'm going to try to pick some that are maybe some rapid fire ones. Can telehealth be cost savings for patients who would normally have to pay an in-office visit fee?
Oh, that's a beautiful question. I think that we still need, like if we go for cost savings and the procedures that we need here on the clinic, of course, I do think that the cost per visit should go down. Because you have less face-to-face time, less time with certain things, and if we actually divide all the costs from a face-to-face visit to a regular one, I think that it will be, I have no idea how, what will be the percentage, but I think that it will be cheaper.
Yeah, I think that's interesting. One thing for people to know and understand is that if you're a healthcare provider and you have a contract with an HMO or a PPO, almost every single one of those contracts says that if you're going to bill the insurance and the patient has a copay, you are required contractually to at least make a good faith effort to collect that copay. So either until any of those things change, the cost per visit to the patient is the same. And so that's definitely something to consider for patients who have it. I think, in our setting, in community health centers and federally qualified health centers, patients don't pay for their visits. So for them, it's been a huge opportunity to have increased access to care. But it's true, for patients who have commercial insurance, you are still required to at least, like I said, make a good faith effort to collect on your copays. So until the private and commercial payers address how they want to do telehealth reimbursement and copays for telehealth, that's still going to be a conversation that needs to be had with those patients, because they just need to be aware. And maybe for them, it's not a financial issue, but they just need to know, because it's unfair to think that they all of a sudden have more access to their doctor and then get a bunch of new bills that they weren't expecting. Somebody had asked, how do you go about choosing which platform you use for telehealth?
Oh my God, that's a beautiful question. I think that we didn't have a choice, and I'm extremely happy that we didn't have a choice, because I think that I was amazed. One of the things that I hate about technology is that you create barriers for the patient. Then that's the thing that I hate. We're all we want them to come and feel safe and reassure them and have the contact. And the more barriers, codes, websites, links, anything that you put on the way creates a barrier and distrust between you and your patient. Then Doximity and Doximity, I think that it was like a simple thing. It protects my cell phone, my line, whatever I'm using, and actually creates a better, amazing communication with my patient. And I love them, because first of all, they are free. And they have high quality, they protect the information, and anybody can use it. If you're a private practice or not in private practice, you can still use it. probably behavioral health can do it the same way. Nutritionists, anybody can actually use it, and the patient doesn't need to do anything. You call them, they click on the link if you want to do visual, like the telehealth with video, and that's it. There's no app, there's no nothing. And of course, right now we're entering the second level because we want to integrate the chart, the electronic chart that we have in the app. And then we will have one more step that they can actually access the video from their cell phone and the app from us. And that actually, it's tricky, but I think on the long term, it will be very important for them to actually access that because they will see their labs and everything else. That's I don't know, what do you think about that one?
So I usually think of when you're choosing a platform, there are basically 3 criteria. One is cost, 2 is integration, and 3 is features. So as Ilan alluded to, you can't beat free as long as it meets your needs. Integration, so for some systems, it's really important that the telehealth platform be integrated into your EHR. Obviously, that's something that some larger companies do and smaller ones don't. And then features are really, when I say features, I mean the integration with peripherals. So, if you are a private practice ENT and you want to send your patients home with a TytoCare digital otoscope, you're going to need to have a platform that can actually take that data immediately. So those are the 3 sort of criteria that I encourage people to think about when they're choosing a platform. But like you said, I think the 4th criteria, and the one that trumps all of them, is how easy is it for your patients to use? Because it can have all the bells and whistles and it integrates into your EHR, and if it means that your patient now has to do like 8 more steps and 3 more logins, like you lost. Like it doesn't matter how fancy it is. There's a question about telehealth documentation. How does telehealth change patient documentation? I think I can just answer this one real quick. The answer is it doesn't. If you're doing a telehealth visit, as long as you're attaching the appropriate telehealth codes, so that's 95 for most payers. A handful of private payers are still using the GT modifier. There's a GQ modifier if you're doing store and forward, but by and large, it's the 95 modifier. A physical exam is not required and vitals are not required. What you do have to do, if you expect your usual level 3, 4, or 5 level of reimbursement, if you are in that kind of reimbursement model, is then your history taking and your medical decision making, aka your assessment and plan, has to be pretty thorough. So ignore your physical, although you can include it if it's relevant, right? If you see the rash on the video, you see the patient's work of breathing, by all means include those. But by and large, you are not required to include a physical exam. So hopefully that helps answer that question. I like this question a lot. So how can patients and advocates play a role in policy reform to support new ways of delivering care? How can we ensure that policy change is beneficial for all and not for some?
I think that I'm very proud to be in a moment, historically, a moment that we're starting to talk about all, and first of all, understand that we have misbehaving with a lot of our population, and this is a moment that we need to start as a base and move forward all together. And one of them is actually try to help, like Tech4Good and organizations that are actually doing a difference as a non-for-profit and pushing them all forward, making sure that you talk, and I don't get tired of saying this, make sure that you talk with your representatives. Make sure that when you hear that there's a bill somewhere talking about telehealth or health per se, because we had a couple of them right now here in California regarding medical and other efforts for fair qualified health centers, and they tried to move another one that was a Proposition 56. They were going to move the tobacco money to other things, and make sure that you stay relevant and make sure that you make noise. That's the key factors here.
Yeah, no, absolutely. I think advocacy has to be heard to be effective. So that's, I think, number one. Specific things that I can think of to focus on advocacy. One is, so here's an interesting thing, at least in the state of California, where we practice, Medicaid and Medicare have been incredibly progressive and have really, they've instituted parity payments, meaning they reform the same they reimburse the same for in-person as they do for telehealth visits since about 2017. The state of California passed a parity law last year that goes into effect in January 2021. But honestly, it's been the private payers who've been lagging, and actually the public payers like Medi-Cal and CCS and Medicare have actually really done a pretty incredible job. So to the extent that whether you have public or private insurance is one of the markers, actually the publicly insured patients have a little bit more access to telehealth from a purely reimbursement standpoint. But making sure that that doesn't go backwards. Like I said, we're lucky in California. California's been very progressive on telehealth and telehealth reform. The other pieces, I think, are actual access to internet and technology. So programs like California Lifeline need to be kept alive, because it doesn't do any good if I'm allowed to be reimbursed for telehealth and I can bill for telehealth if my patient can't actually participate because they have economic barriers. So making sure that California Lifeline stays alive, and programs like Everyone On, supporting organizations that bring internet and high-speed internet to communities that don't have it. The internet was born in the United States, but the United States has the worst internet among high-income countries. It's kind of insane. So talk to the FCC about that. And then the other piece is making sure that there are appropriate protections. One of the beauties and values of telehealth is that, again, is that patients aren't taking off a day of work or a half day of work to participate in their telehealth visits. They just need the 20 minutes or the 30 minutes of their visit. But then I think something that we'll face as more and more people take advantage of telehealth is making sure that employers and schools are giving people the right protections and the right space so that they can actually have their telehealth visits. And we've been partnering closely with LAUSD, and they've been incredible in terms of making sure that they provide a space in schools for patients, for children who are in school to stay in school. They don't have to take a day off, they don't have to miss a day, but that they have a safe, secure, private space that they can go do their telehealth visit in. But I think we're going to have to make sure that employers are providing their employees the same rights to have protected time and space to do telehealth. And again, that should be a low bar, because you're not all of a sudden you're keeping that employee's productivity for the day, and all you needed was to give them an extra 20-minute break, right? Like, don't make them take their lunch break, because that's their lunch break, and don't make them take their regular break, because that's their regular break. They have a doctor's appointment. And so making sure that there's appropriate protection in schools and at work, making sure that patients have access to technology and to the internet, and making sure that Medi-Cal and private payers as well in California start adopting some of the other digital health related codes that CMS has already created that have yet to be passed in the state of California. That includes remote patient monitoring codes and chronic care management codes. Medi-Cal has approved some of the chronic care management codes. They have not approved any of the remote patient monitoring codes. There are lots of reasons for that. Medi-Cal certainly has an approach of, well, we will cover as many people as possible and just cover fewer benefits. And in other states, Medicaid agencies will do, well, we'll cover more benefits, but we'll cover fewer people. So until we start changing the way that we finance Medi-Cal, and we have to deal with finite resources, then I think at least advocating for coverage of the appropriate reimbursement codes will be really important. Carlos, Karen, I know that we're at time. Do we have time for one more question, or should we should wrap it up?
If you got a really good question, let's do it.
I have one that I think is really interesting. Which is the concept of, and I like this because it's sort of thinking further beyond just like regular check-in, which is the idea of telehealth as a modality that is very well suited for the continuous care of high-risk patients, high-risk pregnancies, congestive heart failure, interstage surgery, congenital heart disease for the pediatricians out there. So how do you create programs to support those specific high-risk populations? And you talked a little bit about that, Ilan, about obesity, and so yeah, tell me your thoughts on that.
This is my dream. First of all, we need to figure out that, and we are both doctors. We're very in tune with public health, but in reality, the patient needs to be in the center of everything. And we know that 20% of their health devotes in hospitals, doctors, and pills, and that 80% is actually everything else. And we need to make sure that we create programs like the one that we have that we use community health specialists, that they do social work, they do the social justice part of it, making sure, for example, a CHF patient that needs, right now in COVID times, that they need they need actually food. They need to make sure that they have their medications and other stuff before actually seeing a doctor, because they need to actually eat before. Then we need to figure out the behavioral health of that and see the patient. Right now that we don't have time limit, we have time limitation, but not space limitation. We need to integrate the systems of behavioral health, dentistry, telemedicine, social justice, advocacy, services, and make sure that we create an amazing bubble around the patient, whatever we have. The same thing applies with CHF. The same thing applies with, for example, diabetes. You need a clinical pharmacist that a lot of the times they're just counting pills, but in reality, they can actually manage insulin for the doctor. And a lot of the literature there is that actually they do even better than doctors with managing, the A1Cs and the medications for patients. And we need to integrate all these pieces that we have flown over because we thought that the doctor was the gatekeeper. Right now, we need to open the doors, open the technology, and open the conversation for that.
Yeah, no, I like that a lot. And I think it underlines something that, this conversation has been very provider focused because you and I are providers and people want to know about our experience as providers. But the reality is that we play this much of a role in what patients are doing. I think yours is a little smaller than mine, but yeah, the reality is that we're just one piece of the puzzle. And I mean, I was talking about how well my telehealth clinic flows. That is 5% to do with me and 95% to do with my front office staff, my schedulers, the nurses, like everybody else who also realized that this is important and who is doing an incredible job. The social workers, we have our parent navigators that now we can just engage them through email, right? Like I don't have to find that piece of paper and write it out and walk, down the hall to go hand it to them. It's like, hey, I have a patient who needs some advocacy with their IEP, and they're like, great, we're on it. Send me the name, And so it's everybody else has been so critical to making it successful. And I think that's true of every chronic disease model or high risk model, is that those are team sports, right? And so you have to make sure that the entire team is involved. And I think what you see down the road is that you have better patient outcomes and you have lower costs. The state of Florida 2 years ago did pilots for their high-risk pregnancies where they did these wraparound digital health services. So every mom that was identified as a high-risk pregnancy, they sent them a digital scale, a digital blood pressure cuff, they set them up with a free phone, and they would just have regular check-ins, right? The moms would weigh themselves every week. The program cost $500 in gear. But every high-risk pregnancy is tens of thousands, if not hundreds of thousands of dollars of care. We also saw Propeller Health was one of the first asthma smart device companies to get insurance approval, again, because they were able to demonstrate that the patients who had the better monitoring had fewer ED visits, had better outcomes. There's a couple of congenital heart disease cardiothoracic programs in the Midwest who've experimented with these patients who are incredibly fragile. They've just had one part of their repair and are waiting for the second one, and that is a critical time for them. And those families, they get an iPad, they have a nurse who's on call 24 hours a day for them, and they get a pulse ox at home and a heart rate monitor at home. And again, those families, they feel better, they feel taken care of. But again, you really are able to triage those patients in basically real time, 24 hours a day. And again, those are surgeries and those are patients where when things go wrong, not only are they bad, but they're super expensive. So the tiny outlay in a little bit of equipment and some internet cost and maybe an extra nurse or PA or NP or physician to help manage those patients, you stop one of those surgeries, you pay for the entire program.
My friend, I'm going to do something because usually in regular things we do a selfie with all the providers and everybody that was there. Then if you can smile, that way we can finish the day today. Right, Karen, thank you. Okay, I will send that post. But yes.
Awesome. All right. Well, thank you, Ilan. Thank you, Carlos. Thank you, Karen.
You can tell there's like a lot more to be discussed. I mean, this has like gone on way longer than we planned, and I think it's just we're going to pull together some of these chat questions and send out the video and resources to everybody that's on the mailing list. Very grateful to both of you, to Carlos for being our Zoom guy, and to everybody who contributed to the conversation. Really, really great chat. Thank you, everybody.
Thank you, everyone.
Juan, muchas gracias.
A la orden, gracias a usted.